Good evening all. I'm Dr. Shyam. It's our 10th webinar. Welcome to IDA Ernad branch. Today our topic is full mouth rehabilitations by Dr. ISHARA RIZWANA HAMEED. I welcome our WDC representative, Dr. Rosemary TP, to introduce our faculty. Thank you.
A very good evening, one and all. Dr. ISHARA RIZWANA HAMEED, or Riz, as she is known in the dental circles in UK. Riz qualified from Yenapoya Dental College, Mangalore in 2002 and moved to UK in 2005. After completing her IQU conversion exams, worked in and around Birmingham with some of the best dental practices for around 8 years. During this time, she developed different skills like IV sedation, facial aesthetics, and GDP orthodontics, but her dream was to specialize in prosthodontics. In 2014, she got selected for one of the most sought-after places for prosthodontics at King College, London, for McLeod Pros. The prestigious PG dental department is best known for its research in tooth wear, and the dental school is now ranked as #1 in the world according to the QS World Ranking in 2020. Tooth wear in the main area of interest for Riz, and has also completed her thesis on combined effects of attrition and erosion on enamel and dentine during her course. She completed the course in September 2019 and is now among the 106 lady specialist dentists in prosthodontics in UK. Over to Riz ma'am to take over the presentation.
Thanks a lot, Shyam and Rose, for this opportunity. So I think, I think a lot of my friends are hopefully online. All of you know me as Ishara, but because people found pronouncing Ishara quite hard, and for my patients to remember, so that's how I'm Riz now. So, so let's start the presentation, shall we? Yeah.
Yeah, sure, ma'am. Sure, ma'am.
Okay. So I'll share screen. And I need to share present. Is that okay, Rose?
Yes, ma'am. We can see.
Okay. So hello, everyone. So that's the presentation for today. The topic is full mouth rehabilitation. Okay, let me just quickly come out of this and actually record this chat. 1 second. Just want to record it. Okay, no worries. Let's go back to the presentation. Okay, so the topic for today is full mouth rehabilitation. There is a lot of information on these slides. When I started doing, I thought they told me only a couple of days ago. That means I had 2 days to prepare for the slides. So when they asked for a 2-hour presentation, I said 2 hours is a long time. But when I started preparing the slides, I realized that there is so much information that I would like to share. So I have actually banged up a lot of information in there. In saying that, this is very, if you're a new dentist and, if it's too much for you, what I would suggest at this point is 2 things I want you to have. One is I want you to get a pen and paper, write out all the things that you don't understand. It doesn't matter. You can always ask and we can always go back to it. But make sure you write it because you will forget about it. Second thing is I want all of you all to have a mirror. Get yourself a mirror, anywhere, not a mouth mirror. I know y'all are dying to hold your mouth mirror because no one's been working, but just a mirror so you can see your face. So these two things, pen and paper and mirror. Okay, so let's get started. So about me, Ishara Rizwana Hameed, also known as Riz now in all my dental practice. Like I explained, nobody could remember or pronounce my name correctly. So unfortunately, I had to become Riz, but I love it now actually. Completed my dentistry. I think Rose has gone through all this, but I'm going to quickly go through it anyways. Have to give credit to my dental college, Yanapaya Dental College, Mangalore, proud 97 batch. Completed in 2002, worked in Mumbai as a GDP, and then immigrated to UK. Did my conversion exams in 2006 and started working since 2007. Okay, that's better. So general practice became quite boring. So in 2014, I applied for the MCLIN Dent at King's College, and I was very lucky. That was my second attempt at applying. So yeah, it was a lot of effort, 1 year of complete dedication to get into that course. And thankfully I did. We bought a practice in Norfolk in 2017, and my practice there is limited to only prosthodontics. I also work as a visiting specialist at Guildhall Dental Practice. That's in Bury, St. Edmunds. It's about 40 minutes from where I live. Oh. So this is my world. I'm married to my dental college classmate, Ajisha Ahmed, whom we have two boys. The older one is Izan, and the younger one is Hadi. Izan's 10 and Hadi's 4 years old. We live in Ely. Ely is just in Cambridgeshire County. It's about 20 minutes from Cambridge and about an hour, a bit more than an hour from London. So quite ideally placed. So these two people, I owe all of my success and everything to my parents and their prayers, and because of their prayers and all the blessings from Almighty Lord. So thank you, Papa and Mama, for everything. So what is a rehabilitation? So I am not able to, just trying to see if I can remove. I'm just trying to see if I can make this a bit smaller. Oh, okay, that's fine. Okay. Okay. So what is rehabilitation? So that's the definition from the College of Prosthodontics. I tried to put in, simple word. I'll try to put in basically something that you're reestablishing the whole of the mouth to make it look good, function well, and last well. So basically it adjusts all the teeth, all the gums, and the bite. Those are three main things that we adjust to get it all right. Now, for rehabilitation, there are two things to be considered. One is success. So this is very, very key, is patient satisfaction, because it's a very long journey. It has a lot of possible complications. So the patient journey has to be well defined. One of the most important things for that is to gain consent. So before they get into it, they should understand what they're getting into it, the costs of it, the time scale, the side effects, the possible complications, and then of course any alternate treatment. So you're giving them a whole lot of treatment, so they should know what are their possible options, even considering full clearance and dentures. You've got to give them all of the options. Another is patient management and keeping them pain-free. So looking after them in an emergency, if their crown comes off, those things are real key to success. To be honest, in terms of success in UK, it's actually not getting sued by your patient. And if it is in India, probably not get beaten up, maybe. I don't know. But success is, basically all about the patient. So unfortunately, although we are in a clinical field, we are about, it's a customer satisfaction process as well. predictability of a rehab. Most treatments, so be it crowns, implants, onlays, everything, all of the treatments, if you look at evidences that's been put out, systematic reviews, whatever, they have almost all of them, I won't say all, but almost all of them, they have a success rate in about 90%. So in the first 10 years is what is crucial. So most patients expect whatever they've paid for and that much of effort and pain they've been through, they expect to last for 10 years. And if it doesn't last for 10 years, you're in trouble. So that's your responsibility. So who is this for? So patients who are not bothered about, so who all qualifies to get into having a full mouth rehab? People who are not at all bothered, who have multiple decays, multiple missing teeth, cracked teeth, those people who have not looked after their teeth and now suddenly wants to look after those people. Second is severe attrition. Now, so patients with completely worn down teeth due to bruxism, other habits, that's one. The patients with severe erosion and severe loss of tooth structure. Now, these two obviously, as my thesis was on attrition and erosion, and those two things are both my pet topics. The other is patients born with ectodermal dysplasia, amylogenesis imperfecta, all of that. We've seen a lot of those cases in college. And also then patients who have lost a lot of teeth and oral structures, maybe after cancer or trauma. So they sometimes have full mouth recon along with other facial structures like eye and nose and everything as well. So what I'm going to discuss today is two of those main, among these two, that's number attrition and erosion. The rest is all a little bit beyond the scope of the whole treatment. Okay. I know that you've heard this time and again, the same things. But for me to, and I know occlusion is not nobody's favorite. It never was mine till I really started understanding a little bit about it. So I'm going to try, I've never done this before. In all honesty, this webinar is actually a first for me as well. So, but I'm going to try something. Okay. So these are the 5 principles of ideal occlusion. So we are all working towards ideal occlusion. Okay. So any treatment we provide, so it can be just one single crown unit or a full mouth rehab, either. We want it to get as close as we can to an ideal occlusion, okay? So what I want you to do is, I hope you all have got your mirrors ready. Okay, now because all of you are all, you're not sitting in a crowd, you can just do it in your space at home. So for you to understand this first principle, so ICP, that is intercuspal position, and RCP, both is very important for you to understand. So what I'm going to ask you to do is close your eyes. And because I've tried this both ways, and closing your eyes really helps. So everybody close your eyes. And now try and open your mouth wide and just slowly push your jaw back and just slowly try and close. And the minute your teeth, the first point of contact, open your eyes. Okay, so, okay. Now, from that position where your initial contact, now get into the give maximum force, make all your teeth meet. So that first point, just before that is your RCP or CR in the American style. And when you bite completely is your ICP. Now all the problems. So actually in I don't know, maybe in orthodontics as well, but prosthodontically, so or just generally, like patients who break their teeth or who their teeth are splaying about, or have their multiple restorations keep breaking, crowns fracturing. All this is because of this slide. When you first touch in this RCP, that I'm not all, but I'm saying some of the reasons because of this slide. So what we want to do when we recon, or all the time, what we want to do, so in orthodontics, so only about 10% of the whole population will have an ICP equal to RCP, and I'm one of them. I've had ortho treatment. I think maybe a lot of the people have had ortho treatment. So my ICP and RCP are the same. So that is what we're trying to achieve with, so when you bite down, after you bite, there's no slide. So whatever you're closing down, that's your bite. So that is ICP is equal to RCP. Now, again, close your eyes. Now, mutually protected occlusion, okay? So what you need to do is now from your ICP, that is when you're maximum clenching together, just a fraction when you move your lower jaw forward. The minute you move it forward, only your front teeth should touch and your back teeth should disocclude. And when you're back in ICP, only your back teeth should touch and your front teeth should not take the force. That is a mutually protected occlusion. I don't know if I'm making sense, but it's when it's quite clear in your head, it's very difficult to understand if everybody, what I'm explaining is, it's coming across properly. But actually at this point, I don't mind a little feedback. Rose, Shyam, if one of you can just tell me, is it coming across okay?
Yeah, ma'am.
Yes. Okay, all right. So that's mutually protected occlusion, where the minute you come out anteriorly, your back teeth should disocclude. So that way, if that doesn't happen, so when you're biting together and if your front teeth is taking the load, that is when you get your front teeth to splay, so the front teeth cannot take any load. And if it doesn't disocclude the minute you move forward, that is when you get wear of the cusps or fracture of the cusp when one of the back teeth are still touching when it shouldn't be. So that's a mutually protected occlusion. The third one is anterior guidance. Now, again, close your eyes, bite together, and now slowly move your lower jaw all the way forward, and all the way back. And then now look in the mirror, and then again do all the way forward and all the way back. That's anterior guidance. So ideally, anterior guidance should be on 4 upper teeth. That means all your central incisors on the upper and your 6 lower incisors, incisors and canine, is an ideal occlusion. So when we are going to make an occlusion outside the mouth, that's what we're going to try and do, all 4 upper teeth against all 6 of the lower teeth, so that when the teeth move forward, so there is no other teeth at the back that is meeting because of the mutually protected occlusion. And these teeth don't have the roots, because they've got pointed narrow roots, they don't take a lot of forces. So that's why you want to spread it across all of the incisors. So that's anterior guidance, and we want an anterior guidance spread across everything so that no 1 or 2 teeth take on the force. Now, the fourth important thing, again, I hope you've got your mirrors. It's very important to see this. So bite together, ICP again, everybody. And now you need to move all of you together. We'll try and move to the right side first. And now it's actually quite hard, because patients sometimes, I find it quite hard trying to do this. So this RCP, when you ask a patient to bite, it's very hard for them to get to RCP. So, we have to sort of guide them. Sometimes you might have to, because, they can't sort of, that's why mirror might help. So anyways, bite together in ICP, completely occluding, and move your teeth to one side, the right side. So when you move to the right side, there are 2 ways the teeth can meet, okay? One is canine guided. That means, so you see for me, I'm very canine guided, as in only my canines touch, okay? No other teeth touch. So that is, again, a protective mechanism in which when you move to the side, all your other teeth disocclude, and the strongest teeth in the mouth, that is the canine, the longest root, the biggest circumference, ideally positioned in the arch, is neither an anterior teeth nor a posterior teeth, they take all the load. So it's I mean, we've been like, the mouth has been created to like brilliance. So that's canine guided. Now, a lot of people, I don't know, I don't think it's actually a lot of people. I think it's about 30 to 40%, don't quote me on this. People have something called as group function. So that means not just one teeth, but more than one teeth. That means either canine and premolars, or just the premolars, or all the way across. All the teeth touch on the, so now if you're doing it to the right, we call that the working side. So when you're moving it to the right side is a working side, okay? And all the, as many, if more than one teeth touch, it's called as group function. Now this is the bit. So when we move the teeth in lateral excursion to the working side, to protect all the other teeth, the non-working side, all the teeth should disocclude. So, and I hope you understand. So when you move to the right side, if that's your working side, there should be no contact on your left side. If any of you can feel a contact, that is called a non-working side interference. And that interference will either wear the tooth down or will break it. So it is, or what it'll do is it will transfer forces to other areas in the mouth. So it's very important. If you can feel it, then, you know, get somebody who understands occlusion, you know, or a friend, or try and do it, you know, well, you can try and do it yourself. But what you do is, you know, with an articulating paper, move your teeth to the side and see where your teeth are meeting, and try and ease that off, so that you can actually ease off the non-working side interference. And you can do this for your patients. It's so important. You know, if you're doing, even if you're doing like, you know, if you're just doing one single crown, but that crown, especially if it's like a, you know, lower molars or something like that, that's very, very crucial teeth. When you do one single tooth, it can make, because that might be your first point of contact. So where you get your glide from RCP to ICP. Also about any interference, it's very, very important to check these, even if you're doing single crowns, especially if you're doing posterior ones, because those can be catastrophic. So again, all this leads back to predictability of whatever we do. Okay, so the same thing, try it onto the other side and make sure that, you know, so you understand that that is lateral excursions and lateral guidance. And the fifth thing is posterior stability. Now, our molars are shock absorbers, so they have to, so now every cusp has to meet the opposing teeth. It has to be a cusp to fossa. Basically, it's got to be this cusp to fossa contact. And also there should be a tripod contact. It's very difficult to explain, but it should be something like this. Every cusp will meet a fossa in 3 points in the fossa. So every cusp is sort of, it's just like kind of like holding each. So that, what that does is that puts, so when you're chewing, or, you know, so it just pushes all the forces down the long axis of the tooth, and it's spread to the periodontium, and it goes off. So it is quite important to do that. So that is the 5 principles of ideal occlusion. So hope that was, hope that's made some, got you some, you know, some thinking points. You know, you obviously have to do your own reading and figure out, occlusion's a really long topic. So is everything okay? Rose, Shyam?
Yes, ma'am. It's okay.
Can you see?
Yeah.
Everything's okay, yeah?
Yeah.
Okay, perfect. So now coming to treatment planning approaches in dentistry. Okay, so so it can be anything in dentistry is divided into 2 things. One is confirmative. Confirmative is whatever the patient's biting, however the patient has come in. So they might have, you know, he might not have any of the, you know, ideal occlusion bits, or you may have some. But what we're going to do is whatever they come with, we put 1 extra tooth in, or we put 1 crown in, or we do 1, you know, onlay in, whatever we do, but we don't change anything about their bite. The bite is still the same. that is usually quite an easier approach. It's, the only thing what we need to do is that, when the patient bites, so some people, they bite, once you ask them to bite, so especially when there are not a lot of teeth, or, when they have got pain on one side, what they do is they adapt their mouth to bite, chew in a particular pattern, and then they completely forget what their ICP is. So they will not have a stable ICP. Those people, you cannot do a conformative approach. Anyone who has got people who don't have any signs and symptoms of the TMJ, so whatever they're doing, it's not caused any harm. Those kind of people you can do conformative. Again, obviously single crowns and lesser work. Obviously, you have to do conformative. This I'm talking about in terms of a whole mouth approach, and this may be more like class 1 and class 2 div 1 cases are a bit easier to go conformative, and you can almost apply all the 4 principles except the ICP equal to RCP, the first one. Everything else you can do in a conformative approach. Now, in a reorganized approach, we are the designers. Okay, so we can change everything about this person's occlusion. So what we can do is, so if somebody who does not have a, does not have a correct stable ICP, so if they're doing that, those people who got TMJ problems, so whatever they've been doing with whatever they had, they're actually causing damage. So they're actually biting in some wrong, they have some wrong way, or they are having a slide, or there's a lot of issues in their occlusion. That's why they're having TMJ problems. Those are ideal people to reorganize. And we may need to reorganize in more difficult cases, like class 2 div 2 or class 3 cases. And with reorganize, we can try and get all our 5 principles in occlusion in place. So what is, so now I'm talking specifically in terms of rehabilitation and terms of attrition and erosion cases. So one of the biggest dilemmas that I have come to see is, I'm sure all of you all actually, is lack of space. So the, okay, so what happens is, so as you can see, so let me see actually if I can get a pointer. Yeah. So now you can see here, the teeth, when teeth are gone, there's something called as alveolar compensation. So Crothers and, so it was first described by Berry and Poole, and then Crothers and Sandom, they compared the face heights of young people and without any tooth wear to middle-aged people who got significant tooth wear, and found that the face height is the same. So the tooth reduces, but the teeth keep meeting because the bone keeps growing. Bone and all the periodontium attached to the gum, everything grows, so the teeth can keep meeting. So that space, that was tooth. So the tooth becomes small, but there's no space to just put a composite in and make it a bit better. So this is one of the biggest problems that we have as when we are coming to restore. So how can we create space? Okay, so there are a lot of approaches that we can use. Now, so I just need to explain this. Okay, so when we're trying to get a patient's RCP, I should actually explain it earlier, but RCP is how we try to do. So we have got something called as muscle memory. Okay, so we always bite back. So if I'm biting, and if you ask me to open my mouth and bite back, I always bite back in the same position. Okay, but what we can do is we can actually erase that memory. How do we erase the memory? Is when either with cotton wool roll, or what I use is you get these plastic that you can sort of put in warm water. You just put it in warm water, and then you kind of mold it, and you can put it in the mouth and then let it set. And that kind of, because you want the teeth to be just apart. You don't want them to meet, just want to be. So that's what you do with the Lucia jig. So Lucia jig is made with, how we have cold cure. How we use cold cure, just something like that. It's called Durolay. We make it with Durolay. So we mix it, and then we put it in, and then you got to make sure that the teeth are just, so not just before it meets. Okay, so then we get the patient to do all, so the anterior guidance, we ask the patient to move forward and back, left and back, right and back. So what that does is that creates this little V-shaped notch on that Lucia jig. So what you obviously got to put an articulating paper, and then when they do that, you get the patient's, normal path of movement to closure. There, it's first point of contact. So, what we do that, how we do that is we get the patient to lie right back, okay, and then there are two methods. I think just by holding the chin like this slowly and pushing it back, keeping it open, and then slowly trying to get them to close. Or there's a bimanual method where you hold it obviously from the back like this with both hands and then slowly move it. So this is quite important. Now, I wanted to just mention this. So I had this patient. So she was getting married. She was in her 60s, second marriage, and she came to see me. So, and she's had about two times, or so she had severe class 2 Div 1 case. She was, and so she had a huge maxillary prognathism. And she had, like, her lower jaw was really further back, so it really had like a real class 2 facial profile. So after 2 lots of childhood orthodontics, and as an adult she did another round of orthodontics, and a lot of people played with a lot of things to try and sort her occlusion. So she came to see me when she had only about 1 tooth on one side and 2 teeth on the other side meeting. She came because she couldn't chew and eat. So we wanted to reorganize her bite so that more of her teeth can meet, so that she can eat, because she had a lot of composites done and she was going to have an implant done. So she wanted it sorted before that. And what she told me is, so I was explaining to her that, we always reorganize in RCP. That means we push the lower jaw back and bite. And she was dead against it. She said, I don't want my teeth to be reorganized like that. She insisted that she has to be reorganized in ICP. So I said, ICP is not reproducible, because the minute you keep open for more than 5 minutes, you don't know where you're biting, and then you give me different bites. She said, no, don't worry. I've been practicing this for the last 30 years. So what she does is she postures her lower jaw forward so that her jaw doesn't collapse, and she bites and talks and eats and everything like that. So she's got a lisp in her talk as well, but she's very bothered about that jaw falling back. So obviously you should never be convinced by poor advice from patients. Anyways, silly me, learned my lesson. I accepted that. And so how we do reorganizing a bite is we take, study casts, face bore records, we mount it in an articulator, and then we make, we check where the first, we have to keep adjusting, taking away. So it was actually a lot of composite that I had to remove. I removed that, making sure that the bite keeps staying stable. And then I sort of have a plan, like where the bite, so it keeps moving. So it touches one area, then the next time you do that. So when you remove that first point, then touches somewhere else, like that. Slowly you have to have a plan. It never always goes according to the plan that you do it on an articulator, but still, you still sort of have an idea where so we try that in the mouth. So the first appointment after, so I'm doing it in ICP, where she says, she promised me she will be able to remember where she bites. But after about 3 or 4, not even 4 adjustments of, where the first point of contact, when I adjusted it, she couldn't remember her ICP anymore. And I had done it all on an articulator in ICP. So all that, my plan was all ruined. Then what I did was I did it chair side. So there is a risk of doing it chair side like that, because sometimes, you can just sometimes it might happen that you might have to really remove a lot of enamel from one teeth. So those teeth can become sensitive, or pulp exposure, those kind of things. So always is a good idea to do it on articulator, but obviously with her, we couldn't. And then I reorganized her in RCP, and we got about 4 to 5 occluding contacts on, 4, I think, occluding contacts on either side. And it was, so So my lesson here is, patients will forget their ICP. It is not reproducible. So that's why everything we do reorganized would be a good idea to do it in RCP, which will be ICP after some time. So as soon as we start, so you'll see in my in the slides to come where ICP and RCP just kind of merges, which is ideal occlusion. Okay, so back to topic, creating space. So what we can do is, some people, their ICP is 1, but if you actually reposition the mandible posteriorly, you can actually gain some space. So if you're trying to just, do the, just build up a couple of the teeth, if you actually reorganize the patient in RAP, that means make some adjustments so that the patient, there is no slide and no interferences, then you can actually gain some space just by putting the patient a little, just moving the patient putting into RCP. Second one is increasing OVT. So increasing the OVT, how do I explain that is, so the teeth meet, there is no space for teeth to be increased in length. So we do this, we always do this on an articulator. So we mount it, we get it ready, and then we open up the pin by 1, 2, 3 millimeters, as many millimeters as you want. Usually there is a systematic review that most people can tolerate up to a 5 millimeter increase in OVT. So what we do is we open the pin and then we build up in that space. So how much of a space we need. So we build up in that 2 millimeters. So that's called the increase in the OVT. So this is when we need to, so this is what we do is we'll do a wax up. Once we increase the OVT on the articulator, we do a wax up on the articulator and we try and transfer that. We will have to transfer that to the patient's mouth and see if that suits the patient, because sometimes just by increasing it like the length lower, it just makes them look very goofy or like horsey. So this is when then you might have to consider you have to join it with other things. That is lengthening. So we can lengthen the teeth incisally, but we also need to lengthen teeth cervically or gingivally, and that is called as a crown lengthening. Okay, so I'll come to that. So what is that procedure is called a surgical crown lengthening. So if there is insufficient, so there's a lot of reasons why we do surgical crown lengthening. One is, if the tooth is about 4 millimeters or 5 millimeters long, and ideal tooth length is 10 to 11 millimeters, we can't just increase it on one side because it just looks really silly. So then we'll have to do gingivally as well. Surgical crown lengthening can increase the amount of tooth exposed in about 6 months, can be calculated to about 1.4 to 3.3 millimeters in a systematic review by Picalis et al. In 2016. So you can gain about 1.4 to 3.3 millimeters. As you can probably understand, those are a lot when it comes to mouth, that can make huge differences for a patient. Now, another option what you can obviously do is elective endo, and then when there is insufficient ferrule, and then a post-crown. That's been explained in Elias et al. 2014. Other reasons, so why do we do surgical crown lengthening? So if you've got a gummy smile, so you show a lot of your gum, or your gingival zeniths are not even, or if you've got subgingival caries in some areas, then anyone a restorative, those are the reasons why you do surgical crown lengthening. Some of the possible complications are loss of vitality. So because we're preparing the bone, it can rebound. It can cause mobility because we're taking off the crown root ratio. We're increasing the crown to root ratio. So obviously that mobility is possible, and obviously we're taking away bone around the tooth. It can cause black triangles on the front, which is a very common scenario. Sensitivity and gingival recession. So these are some possible complications of. So what is surgical crown? So this is one of my patients has seen. So he came to me and he was advised extraction of these 4 front teeth. As you can see, he's got severe, it's actually attrition because of the porcelain surfaces that he's actually worn these teeth down. But as you can see here, this whole area is compensated. So it's all of it's grown, all of it's grown to meet. So patient wanted some option. So he didn't want a denture. He didn't want to have an implant yet, and he wanted to try and save these somehow. Although the crown root ratio was not ideal for him, as you can see, almost all his pulp is exposed. So for him, we decided to try with all knowledge of the fact that it may not work, and he was willing to take that risk. We did surgical crown lengthening of these 4 teeth. So this is how it looked before. This is how it looks straight after it was exposed. So as you can see, there's not a lot of tooth there to save it. The only thing we can do for this sort of teeth is a crown. I don't think I know composite's going to stay. So other than extraction, then the option was to just go all in: surgical crown lengthening, root canal, elective, and then crowns. So this is what we have to do. So what I did is I did a wax up on all these teeth and gave them an idea of exactly how long I want my crowns to be. And then we give them what we call a surgical stent made from our wax up. So they know exactly how long we want our crowns to be. And then what they do is they make sure that they remove 3 millimeters of bone to provide for biologic width from the bottom of the crown. So that's what's been done here, where they've removed, so they have to remove interproximal bone all around the bone to gain the length. And this is just straight after surgery. Everything's put back together, and this is 6 weeks post-operative. So this is a very painful procedure for the patient. So we really need to think this through before we go ahead with this, but that is one of the options. Surgical crown lengthening or increasing OVD and surgical crown lengthening both together. Now, another way of creating space, you must have heard of this, the Dahl method. So in 1975, there was one case report that was done by Dahl where he placed it was a removal, I think it was an orthodontic correction, I can't remember now, I read it a while ago, but when the only anterior teeth were kept in contact, after about 4 to 6 months, the posterior teeth over erupted to meet. So when this appliance was removed, there was anterior space created. So a lot of studies have been done by Dahl and Krogstad in 1982, 83, 85, and then, so this technique is used when you're, reconstructing a full worn dentition. So when you have only localized tooth wear. So, so that is the biggest disadvantage of a reorganized approach. So for example, again, you have a mirror with you. Just take anything. For example, take a pencil. Okay, if you put just your normal ICP again, try and put a pencil. This is what I do for my patients. I take a probe and I put it there and I say, what happens when, well, even one small thing as a probe is about 0.5 millimeters thickness. If you put it in there, none of your other teeth meet. Okay, so this is the problem of a reorganized approach. The minute you're reorganizing, that means the minute you're going to add to one teeth, that means you're committing to all of the teeth, so that all the teeth will have to meet, because obviously everybody needs to eat and chew. So the minute you commit to one teeth, you have to do something about all the teeth. Now, what do you want to do all the teeth is something that you have to decide on a teeth by teeth basis and on a person by person basis. So one of the things, so if all the teeth at the back, so patients got only anterior tooth wear and all the teeth are good virgin teeth at the back, you don't want to be starting to prep them or, even onlays. They all have their own problems. Then what we try is something called as the DAL method. So what we do is we either do this in, we do it as provisional. So we build up the front teeth. So the posterior teeth disocclude and then we give it 4 to 6 months. And I think it's 96% of the time, I'm not really sure though, 96% of the time the teeth come to meet or partially meet in 4 to 6 months time. So almost, everybody, you can say, only very few people who don't dull. So this can be this. So now you can dull either on provisionals. So you can dull on maybe composites. You can dull on provisional. So that means prepare the teeth and put provisionals in and then let the teeth come down. Or you can just, some people even dull on definitives. That means, so like I do a lot of definitives is when I do resin bonded bridges. So when there is a patient who's got one teeth missing, and if I think, their teeth, I don't want to prepare any teeth, they don't want to have implants, then I just do a resin bonded bridge. So have a wing on the adjacent teeth and leave the teeth high in occlusion. That means that's the only teeth that they will meet. But what happens is all the other teeth just fall into place. And I've had very good success rate with leaving the teeth high in occlusion. That's with my definitives. I have also done it for premolars, coming off molars, premolar off premolar. It's a very good option. You can also do this if you're going to do like place an implant later on, but you don't want to do immediate loading. Then you just, as a temporary, instead of putting a denture in, you can use a resin bonded bridge as well. So how do we do the DAL method? So obviously the fourth one is tooth preparation, and all of us know what tooth preparation is. There's no space. We prepare the teeth down, cut it down to, we need 2 millimeters incisal and about 1 millimeter all around. Cut the teeth right down to put a crown on top. So tooth preparation, we all know about it. It is an aggressive form, so it actually causes, it always comes with, its own problems of, loss of vitality and basically compromising the whole tooth. The minute you take a birth to a tooth, you're giving it 10 years from then. And, I'm 40 years old, and even 10 years from now, I don't want to be losing any of my teeth. So remember that. So tooth preparation is but one of the options, but it should not be the only option in your. So now I'm just going to explain DAL concept a little bit more. So this is one of the patients. So he had severe erosive wear on these front 4 teeth. Can you see? There is really a lot of wear, and he's really severely overclosed. He came to me, his concern was that he wants to protect these teeth and don't want to lose further teeth, and he wanted a denture. He said he couldn't chew on one side. So this is a case where he used to drink lime water every day in the morning. He's an Indian, very friendly man. He used to drink lime in water, which is considered to be very healthy. But unfortunately, this is what happens. This is about 2 or 3 years in, 4 years, I think I saw him after. So when we came, initial plan was that we're going to change these ugly looking crowns, and he was bothered about the spaces in between his teeth. So the definitive plan was to put some new crowns and new crowns on these teeth, and possibly even crown these teeth and have some change all these crowns was the initial plan. So what I did is, because these teeth at the back looked, as you can see, they're, there's not much wear, there's no issues on them. So we decided to DAL him. So what we did do is we took some impressions and face bow records, mounted it on the articulator, and then I did some wax up to increase the OVD. And then what we decided to do is I decided to provisionally do composite buildup. So basically increase it by, I think, by 2 millimeters, and then let everything dull. I don't have any pictures to show how it looked after we went to this, but this is actually after 6 months. And as you can see, all the teeth reestablished contact after 6 months. So initially only these 4 teeth were meeting, but eventually all the teeth came into contact. So at this time, when he came back, we were supposed to change these crowns, but then he was so happy with this really not so good composite work. I mean, obviously, you know, this I did when I was, a while ago, let's say. And it needs a lot of polishing up and shape, and everything can be adjusted. But but he was very happy with this treatment, and he said all he wanted was a chrome denture, and said then we just made a chrome denture for him. That's it. So actually, although we planned a lot of treatment for him, he was quite happy with. But this is what DAL is about. Okay, and the 5th method for creating space is orthodontics. So, you know, orthodontics for space, you know how you can, ortho's used for a lot of pre-prosthetic treatments. So that's one of the things. So how we usually do is we either do upper and lower incisor and canine intrusion, which is not a very stable method, or we do upper and lower proclination to gain some space, or molar and premolar extrusion. So we make them come out so that we can just gain some space. But this has to be done by somebody with a fixed appliance, and it requires real expertise. So this is actually by a case on BDJ by R.D. Evans. So just to explain how it is orthodontics can be used. So tooth surface loss. Anterior was an edge-to-edge bite, as you can see. Severe acid erosion shown on these teeth. So what was done was a teeth was extracted in the lower mandible. So I think the right one was extracted, and the mandibular appliance, and all the teeth were intruded, and then that just created space. See, as you can see, there's a lot of space there for improving and putting some restorations on and protecting these teeth. So that's about creating space and how you can create space. So I know you might actually having a lot of questions and queries. If this is not things that you've already heard, do write it down and we can come to it at another time, later today. So how much space do we need? So this is Pascal Menier has given, there is this Menier et al. 2003, in which he actually measured extracted teeth, worn and unworn teeth. And these are the averages he's come out with. So central incisors, unworn is about 11.6 millimeters into 9 millimeters. That's a width, and so the number of teeth he measured, that's the N in there. It says, so he's done 18, he's measured on 18 teeth, and that's how the worn teeth look like. So basically, if you're restoring a young person, you want to be more towards this, and if you're a bit more older person, then you want to look at more of these kind of statistics. But this is an amazing paper which just gives you an idea of how much space we need for each patient. So you have to measure. So again, with the Williams graduated probe, you got to measure each tooth and then sort of decide how much more you want. And depending on how much more you need, then we need to decide how you're going to gain that space. And then have that, obviously you have to discuss it with the patient and see if that's something that they want to do. So this systematic review by Abdu et al. 2012, isn't it? Yeah. So it says that if you increase the OVD for up to 5 millimeters, I did say this earlier, it causes minimal and self-limiting discomfort for the patient. So you can increase the OVD for up to 5 millimeters. So coming to treatment options. So you got anterior tooth wear. Okay, tooth wear, tooth is reduced to, a lot. What are your treatment options? So I'm just going to explain and I'll show you what these mean. So the first 3 are palatal veneers. So instead of buccal veneers, it's erosion most of the time is happening on the palatal side of the upper anterior teeth. This is because, either you get acid reflux from the stomach, or, when you're having, drinking, everything. It's almost always on the insides of the mouth. But again, some people have habits of holding the drinks out in the mouth, or, there are some habits of, maybe swimming, or, people in battery factories. Those kind of people have buccal erosions, or maybe a combination of erosion and abrasion. But most of the time it's actually palatal. So that's why a lot of this is, so it's either nickel chromium palatal veneer, gold palatal veneer, or indirect palatal veneer. Indirect composite palatal veneer, or you can even do it as a direct composite, but those are not that easy to do. Porcelain veneers, and then you can do hybrids of these. So you can have a hybrid is gold veneer palatally and composite direct buccally, or gold veneer palatally and porcelain like an Emax veneer buccally, or indirect composite palatally and direct composite buccally. So you can have hybrids of these, or you can have the traditional metal ceramic crowns, where there is only metal palatally. So the prep is minimal, but there's still, and we could add to that is all ceramic, but that's very, but particularly these days with verti preps and things like that, you can actually you should consider all ceramic as well into this list. So this is a very nice flow chart I saw in Chu et al. 2002. It's for localized tooth wear, and it just gives very simple. So, if there's any pathological signs, if there's pulp exposure, that's when you decide for treatment. And then, if there is no pathological signs, then we just monitor it. If there is now adequate occlusal clearance, yes, then, involvement of, if there is involvement of incisal surfaces, is there adequate crown height? If there is adequate crown height, then, you can do full veneers or double veneers. That means palatal gold veneer and buccal ceramic veneer, something like that. Now, if there is no inadequate clearance, then you get to create space. How do you create space? Like we just discussed, different options of creating space. Now, if the label surfaces are involved, yes, then we need, is there adequate? If there is no involvement of the label surfaces, that means, like I showed you the case just before, his buccal was actually really okay. It was only the palatal, but I just added the space because of some spaces. But so there's only palatal, then all you need is some palatal backings like veneers. So it can be either gold or nickel chromium, like I said, or resin or porcelain. So those are your options. And then if there is inadequate crown height, like I said, then we'll need to do surgical crown lengthening and then come back and do crowns if there's inadequate crown height. So those are the treatments. That's a really nice flow chart for you to, that's for localized anterior tooth wear. So this is a case, patient. She was anorexic. So this patient's actually only 28 or 29 years old. Very nice patient, but severely anorexic. That anorexia nervosa. So that means she will vomit that all that she eats, and she cannot help it. And then when she came to see me, she was in remission, and she said she does it only 2 or 3 times a day. She still does it, but only 2 or 3 times a day. So imagine somebody who's going through that trauma of not having able to hold their food in. So they've got a lot of mental challenges. You've got to really deal with these patients very carefully and with a lot of empathy. So anyways, this patient, she came to me. So she's had one lot of treatment done from by a dentist where they've done some veneers, but then she went back into it and she was not bothered. And then now she's come back, she's very motivated, but she came back with a lot, her gums were looking like that, a lot of non-looked after teeth. So it was a lot of obviously advice and support oral hygiene regime, advising to go see the hygienist, and slowly getting her to. So this is, so we had to motivate her, and about 2-3 times she had to come back to see me till we got her to where we thought, okay, she was ready for treatment. Then at that point, when she came, so this was initial presentation. So once everything was stabilized, then we did some impressions, our face bow record, and then articulated. And this is the wax up I did. So from the wax up, we realized that we can actually go, there is enough space there to go conformative for her. That means we didn't have to change her occlusion, which is actually quite good. You can't really see it, but there is a lot of palatal wear here, that there is enough space to put the composite on. So then we decided to, because of her young age, we decided to do minimal invasive treatment options. So we went for composite. So this is the mock-up in the mouth. So again, like I said, the crucial thing is the patient should be happy with the treatment. And how do we know the patient will be happy? Because what we think is beautiful is not exactly what they understand as beauty. Beauty is in each person's perception. So that's what the wax up does. It shows them the end product. And then if they're happy and they want to go through it, then we work backwards. Very, very important for you to keep that in mind. So always have to do a wax up, show it to the patients. So what we do is this wax up, we make a putty mold around this, we make a matrix in it, and then put Pro-Tem, or whichever brand that you all use. Basically, it's an acrylic flow, or is it, resin flow material. And then we put it in the patient's mouth, and we sort of wait for it to set and then remove, and then sort of adjust a little bit. Obviously, I've adjusted a lot for, because for photographs, but yeah, sort of basically show the patient what I always do at this point is, again, if it's a selling technique as well, where I always get at mock-up stage, get a patient to, on their own phone, take a video of them talking, take lots of photos of them, so that they can go back away and think about it, and if they like something, if they don't like, because it's a great communication tool to do this wax up and mock up, and I advise it for anybody you're doing any aesthetic work. So then what we did is, for her, we did indirect palatal composite veneers, and buccal is actually a direct, so that's actually my handiwork. Well, not good, but yeah, all these need a bit of polishing. So this is the same case. So this is how she presented. As you can see, severe erosive wear. This is all composites that you can see that's been built up. So what we did is, once everything was stabilized, as you can see, the gingivitis all around, which is all stable. So once it was stable, then we removed all of the old fillings and tried to preserve as much. So what I like to use is a rose head, a big rose head round, or like a tapered rose head burr. I use that. So I removed all the remaining composites. We just took an impression, and then got the lab to conform to her occlusion. And so there are 6, canine to canine is indirect palatal veneers. So I didn't take a picture of it at that time. So what I did is I cemented the palatal veneers, and then I used that as a guide to build it up buccally as direct composite veneers. So very minimal preparation. And then we just did some direct composites on these. Both the first molars were crowned. This one particularly, this was subgingival, so we had to remove some of the gingiva there with an electro surgical kit, and then we prepped that teeth, and then gold crown. Patient was very happy with the result, and I think it was very good for her. So why I put this slide, this is another patient. So I didn't do this work, but I just wanted to show you what gold palatal backings look like. So this patient came to me because she lost one of her gold palatal backings on this tooth, and she lost her crown on this tooth, and she wanted that sorted. But I just wanted to show you this picture. This is gold palatal backings. This is very minimal, exactly the procedure as you're doing a composite. So all you do is take off, whatever composite or restoration material that is there, take an impression, ask the lab to make the gold palatal backings, and literally cement it on with Panavia. I'd say Panavia more than anything, but yeah, anything that's a bonding system, that's good. So all I did was I just cleared that and took another impression for a palatal veneer. So it was palatal gold backings with buccal direct composite. This is actually done by one of my teachers. So I just wanted to show you what palatal. So this is the treatment for one of the treatments for anterior treatment. So now coming to posterior localized wear or posterior wear, what you can do is what we need to remember is the patients are coming to us with wear. Wear is where the enamel's gone. So the minute you take a burr, you're doing what wear they would have done in 10 years time in 1 hour, taking all that enamel away. So you got to really, for wear patients, you really need to think this through. So what are the options? You can have nickel chromium or gold onlays, indirect composite onlays, full gold crowns. Now this, as it goes down, it goes more and more prep. You can have a metal ceramic crown. That is the, I don't know, we say probably PBC in India, like a porcelain bonded crown. So here we mentioned this metal ceramic crown is the same thing. And then an all ceramic crown. So these are the options for posterior treatment. And again, from Chu et al. So localized posterior wear, what do you do? If there's adequate interocclusal space, so there is adequate interocclusal space, then yes, and you need to just cast for restoration. So like endodontally treated teeth or as a bridge abutment. If not, if they don't need to be used as that, if it's endodontically treated or if it's a bridge, then you need an extra, sorry, let me look at that. Need the cast for cuspal protection. Okay, so if there is more than two-thirds of the tooth structure missing, then it would be a good idea to get an extracoronal restoration. So if there is no need for an extracoronal, then you can do so an extracoronal is like an onlay or anything that covers, okay? Or you can have an intracoronal restoration like a composite filling or inlays. So now if they need cuspal protection, then is there enough tooth structure left? If there's enough tooth structure left, just go for partial crowns, full veneer crowns, onlays, adhesive onlays, all of that. Now, if there is not enough tooth structure left, and you have to either do core buildup with restorations, elective endodontics, or surgical crown lengthening to create space, and then we need to do extracoronal restoration. So if there is not enough adequate interocclusal space, then we have to either reduce, so we need to create space, either reduce the opposing teeth, so you can intrude an over-erupted teeth. Then the other things like increasing the OVD or fixed appliances, like we discussed, for creating space. That's what's mentioned here. So that's Chu et al. That's a very good, you can check that out. So the treatment options. Now, this is the important bit. The patient has to be aware of the risks, the benefits, the limitations, the long-term prognosis. That means how long and what will happen after 2 years, after 5 years, the long-term prognosis of each approach when making decisions regarding management of tooth wear, okay? Indirect restorations are generally less conservative. That means, like I said, what wear they would have had in 10 years, you're giving that wear in about an hour. So it's not that conservative and often require for indirect restorations. The consequence of failure of indirect restorations are quite catastrophic, like loss of vitality, crown fracture, and irreversible most of the time. But with composites, the direct restorations, although it's not catastrophic failures, the failures are more. That means, staining, chipping. This is the only study that compares both the crowns and composites on a wear case. There's not a lot of cases that's done on wear. Composites, you have to give the patient about 4 to 5 years, saying that, this is a complication of doing it composite way. But, these days composites with some, making sure that you follow the protocol for etching and bonding very, very well, using what do you say? The micro abrasion with like sandblasting, intraoral sandblast. I couldn't get the word. Like an intraoral sandblaster, you could just kind of get on the teeth, and then the bonding is really good. You have to have an intraoral sandblaster. It's amazing, especially if you're doing a lot of adhesive work. So this is the main part of our presentation. So are we on time? Are we okay for time? Shyam?
Yes, ma'am. Yes,
Yeah.
doctor.
How much more longer do I have?
You can have it around 20 minutes more. It's okay.
Okay, only 20 minutes more. Okay. Okay, so coming to case, patient presented. So patient PP, 70 years old, severe erosive wear with a little bit of attrition and abrasion. She's got missing mandibular posterior teeth. Her concerns were the appearance of, she was not happy with the appearance of anterior teeth, inability to chew. So she was treated with both direct and indirect restorations at an increased OVD. Her problem was she had Sjogren syndrome, so she could not tolerate a denture. So this is her. So she had severe erosive tooth wear, as you can see, and she's got all the teeth missing. She's got only her lower 3 to 3. So she has a low average smile line. So smile lines are high, low, and average. She had an average, so which just actually works in our favor. She has reduced saliva, and this is her BPE and BV. BV is how we record and monitor tooth wear. No time for that though this time. Now, occlusal features class 3, and that's her protrusion and guidance. So that's her OPG. Radiograph. So what we decided to do was to crown, increase the OVD. So the minute we increase the OVD, we are, and all these were really heavily restored teeth. So for that reason, we decided to crown them, and implants, 2 implants on either side to restore them. So this is the normal treatment plan that we follow. So immediate phase, we stabilize disease, we review it. In transitional, we place the implants, and we prepare all the teeth and gave provisional restorations and direct composites on the lower 6 teeth. And then final restoration was metal ceramic crowns on all of the upper and restore the implants and a stabilization splint. So this is what we did is Alginate impressions. We take the RCP record, face per record, move it into a semi-adjustable articulator. Semi-adjustable articulator is a must or a minimum because you cannot do your anterior guidance and lateral guidance on an average value articulator. So there's no point. You can't do ideal occlusion. So you need to have a semi-adjustable articulator. So this is, we had to do our own wax up. So this is wax up done by me. And then we did a mock-up, like I said, explain to show the patient where we want to be. Like I said, we always work backwards. So this is our starting point. So once that's done, we did a CBCT. So from the wax up, we made radiographic stent. As you can see, my radiographic stent there. We did CBCT. So the 4 and 5 area, the canals was quite close, so we had to use quite small implants. So we used 6 and 8 millimeter implants. We didn't want to have a long span bridge and move it further back because she had dexterity tissues and she also had Sjogren's, so there was not enough saliva. So this is stage 1, implant placement with a surgical stent to guide us. And that's stage 2, opened it up in 3 months' time and put healing abutments on. So this is the provisional phase. So prepared all the teeth. And so as soon as we prepare, we put just temporaries with just Pro-Tem. We make temporaries with Pro-Tem and then cement it on. Then with the impressions, we asked the lab to make some provisional crowns, but we have to do our own provisional crowns in college. So that was provisional crowns were done by me. So this is Loa's Astra implant impression pickup and provisional implants placed. So this is the provisional phase, prepared all the teeth, took an silicone impression. As you can see, all crown preps have got retraction cords in them. And this is my provisional. So these are Gradia crowns. This is made by me again in the lab. So this is the best method to learn how to sort occlusion. Everything you want to learn, you got it in there. So definitive phase. So tooth preparations were refined for metal ceramic. Now we leave the patient in provisionals for them to get used to the aesthetics and the occlusion. Everything is corrected on the provisionals. Then we take an impression of the provisionals for the lab to replicate that in the definitives. Phase bore record was again taken, and then this is metal trine, although it is opaque just before ceramic goes on. And then we try it on with a metal because obviously it's my exam case. I want to try it with metal and make sure the occlusion's perfect. And then this is the definite. So we put the 2 implants were linked because they were quite short implants. So I linked them. So we made them into uni abutments, and this is a uni abutment pickup. And definitives, we also changed the lower anteriors with composites, and then we gave a patient a splint as well. And that's a radiograph. So this is where she was pre-treatment, and this is where we ended up post-treatment, as you can see, metal palatal backings. Second case, 59-year-old female. She had severe erosive wear. So, and she also had quite a few missing teeth, and she wanted a replacement. She had hiatus hernia, and she also had anorexia nervosa, so a lot of erosive wear. She had a very high gummy smile, and she had class 1 and class 3 missing teeth. Those are her BPs and BVs. Let's skip through that. So this is where she was pre-treatment, a lot of tooth wear. As you can see, that teeth was almost pulpal exposed. She was in pain. We had to do a root canal for that, and quite a few teeth missing. Those are the radiographs. So after this, we decided to actually have metal ceramic crowns, surgical crown lengthening to increase the length of the teeth, and cobalt chrome dentures. So this is the initial plan to relieve. She was in pain on the upper left 3. Then surgical crown lengthening of the upper anterior 3 to 3, and then provisional restorations on all the other teeth, and then MCC crowns and chrome dentures. So the diagnostic phase, so for surgical crown lengthening, what we have to do is we have to do something called as trial preparation. So what we do is we prepare just like in the mouth, but on a cast to see if there's sufficient tooth structure left after the trial preparation. If it is sufficient tooth structure, if it's not sufficient, that's when we'll have to do a surgical crown lengthening to increase the crown height. So anteriorly, you need about 3 millimeters of crown height for a crown to be, and for posteriorly, you need about 4 millimeters. So that's so this is how we've done. Wax up, that's again done by me, and trial denture in the correct OVD. That's after the OVDs increase. So we take the occlusion in RCP, and then we open up the bite till how much over we want it to become ideal tooth length. So like Pascal Mayonnaise. Then we try it in the patient's mouth. As you can see in this one, is actually quite long because these teeth were long. So we actually decided she looked a bit goofy. She's not showing, she's got a very gummy smile as well. So for that reason, we decided to crown lengthen her. This is trial preparations, and there is insufficient tooth structure, so we decided to go for crown lengthening. This is the cobalt chrome denture design. That's for another day. Then what we did was we do another wax up with reducing the length incisally and moving it palatally to keep the length. And this is all, and then we make a stent from this wax up, give it to our periodontal colleagues. What they do is then they keep that there, and then 3 millimeters of bone from here has to be removed to preserve biologic width. So this is the crown, and then 3 millimeters from them have to be removed, so that you can see here bone is removed. And this is 4 weeks post-op, 2 weeks post-op. So at this point, what happened is, as you can see, they removed a lot more bone on this side, so it's a lot more than what I had said. And so it was, the gingival zeniths were not even, but the patient was not happy for any, she was happy with whatever was there, and she didn't want a revision surgery. It was very painful surgery, these surgical crown lengthenings. Then, when she came back in her four-week visit, I prepped all her teeth, put linked temporaries in. So after surgical crown lengthening, take more impressions, and then do another wax up, because it all changes. And then we use that wax up to make a provisional crown. That's my provisional prepared and impressions. Then at provisional stage, what happened is we put the provisionals in, send the patient off, and 4 weeks later, she comes back with this. She's broken up her front tooth. This is my exam case, and I was, fretting. So we gave her all these options, either root canal post or bridge or extraction. But the patient chose extraction and addition to the denture. So that's what he did. Extraction and immediate addition to the denture. Left it, and then prepare the teeth for my definitives. All the teeth on the lowers were prepared for definitives. Impressions for definitive crowns, and metal try-in, and that's my definitive crowns in. So now, because this is fixed removal case, wherein, so it used to be where if you want to have a denture to have good retention, they used to make something called as precision attachment. So there is something sticking out of the crown here called precision attachment, and you have a hole with a rubber thing in, so it'll be like a ball and socket joint, but so the ball on the crown and the rubber bit inside the denture, but those have a lot of problems. So this can you see like a milled ledge here? So this is a milled ledge. You make mill ledges, and there's my mill ledge on there and there. So for the crown to seat. So again, it's very important at this stage to give the lab real clear instructions, the denture design, ask them to prepare the crown with rest seats, guide planes, and mill ledges, and also, buccally for an undercut for your class 2. So you have to give all that instructions when you're giving it to the lab. Then at this point, you take impressions of that for chrome. So this is on special trays, bottom molded. And as you can see, you've got to make sure that you really get all of the ledges, mill ledges in your impression. And then this is the metal try-in of the chrome denture. So that's the metal chrome denture, upper and lower. Then that's wax try-in. Now this is the wax and the metal try-in together, merged. And then this is the pre-treatment photographs. This is where the patient was, and that's the post-treatment. As you can see, so she's got very gummy smile. So she doesn't show it much here. She would never, but so this is after surgical crown lengthening. But this can you see this lateral is much longer because there was that discrepancy after the perio surgery, but patient was very happy with the results, so I accepted that. So that's fixed. So mill ledges. So this is mill ledges. This what I've recently now done a case where I got my lab to do milled ledge on a zirconia. So we don't really need to have this ugly looking crowns, and we can do it on mill ledges on zirconia, on full contour zirconia, and it was a really good result for a chrome denture. So a few things that you need to remember is you should have at least 3 mill ledges to just give the tripod effect. Mill ledges also act as support, so prevent the denture from seating down too much. So it just holds it up, gives support. and also it's best to avoid the incisor teeth because they're not very good teeth first. So key points: occlusion is a success. You need to get it really right. Face bow, you will need a semi-adjustable articulator. Treatment is done in reverse, so you know exactly where you want to be, and then you work backwards. And the biggest thing is your communication to your lab it's crucial. Okay, I have got another little presentation because I was asked crowns. I'll just quickly run through it. Is that okay, Sham?
Yes, doc.
So some of the things that has changed the way I practice eyewear loops. I wear 2.8 orthoscopic loop, which is not ideal. I'd like to actually now jump up. But for a prosthodontist, you need to have a field of view as well. In saying that, a lot of prosthodontists are now working with microscopes. We do have a microscope. I've never ventured in that. But that's got a learning curve, and I'm sure that's something we have to go to. Light. I have a loops with light, and it absolutely changes everything. You need to have a comfortable chair. Prosthodontics, as you can see, is a long treatment, and preparing that many teeth in one go can be killer. So I use a saddle chair, and I always make sure my saddle is where I can't lean forward, so I have to sit up straight. It is amazing. Speed increasing handpiece, it's amazing. So delivers a continuous torque. So, and you can use the same burst. It looks like a micro motor, like a slow speed. Actually, it takes on the burst that we use for high speed. It's amazing. Matrix, putty matrix for checking the preparations. So we take putty matrix before we start the preparation. So we make two of them. One is to make a temporary out, and one is to use it as a matrix to cut it and see if you're following the shape. So obviously if you don't, that means we know that we have encroached the pulp on one side so that we can follow it through. We've got to use new burrs. It's a good idea because it otherwise really damages the pulp, and the patient coming back with, needing a root canal after you've done a crown is really pathetic for us, because we just feel really bad. So, I always use a Williams probe to measure the prep on all sides to be equal. Right, what else? New burrs. These are called as wedge fenders. So what you do is, it's like a little wedge, and then it's got like a little matrix band, or you can just use them to make sure that don't touch the adjacent teeth. Gotta be careful. It's not worth it. Don't damage by trying to, cut one tooth and cut the teeth adjacent. These are depth cut grooves, very good. This helps you, be even and uniform. It's really good. I'd advise you to get some of the depth cutting grooves. So occlusally, most of the problem times it's that there is insufficient occlusal clearance. And when that happens, the patient, so that's the advantage of doing your own provisionals and everything in the lab. That's the best thing. So when you get, when you get your crown preps back, try and do with a composite or whatever. Just try and do a crown on it, and then you'll understand all your mistakes. It's the best way to learn. So, quick basic guidelines is just the Goodacre et al. 2001 paper. So it gives us a lot of guidance. First thing is the total convergence angle. So this is the convergence angle from this side and this side of the crown prep. When they converge, what angle they make. So ideal convergence angle should be about 10 to 20 degrees. And this is, if you're very, very parallel, it's very retentive. And then as your convergent angle increases, the retention goes down. This is the taper. So they say about 6-degree taper, but to even be able to visibly see it, I think it's about 12 degrees. So which is similar to the like a good chamfer burr. So you need to really pick your burrs. So yeah, that's another thing about tips and tricks. I always try and use the same few burrs, just the same few burrs. So you just know exactly where your preparation margins, what the thickness is, everything. Okay. So this is what we discussed earlier. For an ideal prep, you should have at least 3 millimeters minimal incisally or incisors and premolars, and 4 millimeters for molars. For retention, retention form and resistance form. Now, the length, the height of the prep should be more than the width. That's what that says. Teeth should be, the corners should be preserved. So, you know, keep it as straight. Don't round it off too much. You don't want to be too, but it kind of, that's where your resistance forms. So if you want to lift up like this, if you bite like this, if you want to lift up, if there is good resistance form, it doesn't lift off, as in the margins are good. Then you can use grooves and boxes. Again, amazing, especially if you're using mandibular teeth as a part of a fixed dent, you know, FPD, like a bridge. I always give like proximal cuts, like it's just a groove, but that really holds, gives the tooth a lot of retention. Now, condition permits, so finish line should be supragingival if at all possible. But another thing is it should not encroach into the epithelial attachment or the biologic width. If it's thin, it's a thin type gingival phenotype, it causes a recession. If it's a thick type, it causes chronic inflammation. So you must see some patients with a crown and then a chronic inflammation. That's because it's the margin is subgingival and it's encroaching onto the biologic width, and that teeth needs a crown lengthening to sort itself out, sort that problem. Finish lines for MCCs, you know, it's actually personal preference. So depending on aesthetics, you know, formation, ease of it, ease of treatment, type of crown, all those are the reasons how you decide on a finish line for an MCC. So you can have, you know, the butt joint, the chamfer, the shoulder, the bevel, everything. Now, both the shoulder or chamfer can do for all ceramic crowns because now bonded crowns, I'm going to come to that. Depths greater than 1 millimeter is usually not required. So remember that we don't, even for all ceramic, you don't need more than 1 millimeter prep. So, you know, when you take that matrix, putty matrix, you can tell. Okay, occlusal reduction for all ceramic crowns, 0.5 to 1 millimeter deep. For metal ceramic crowns, that is PVC crowns, we need more than 1 millimeter. So we need to provide for the metal and then for the ceramic. So it has to be, occlusal clearance has to be more than 1 millimeter. 1 millimeter all around and 2 millimeters occlusally. And if it's functional cusp, that means the upper palatal and lower buccal. The functional cusp need more than 2, that's about 2.5, I think. All ceramic, it is not necessary to exceed the 1 millimeter axial reduction, that means all around, and 2 millimeter incisal reduction. Angles should be rounded because it reduces stress in ceramic. And in metal ceramic, it's to facilitate basically better pouring of impression investments and a smooth tooth preparation. So now, all of this, mentioned in Goodacre et al. 2001 is for conventional cements. Now, because of the advent of resin bonded cements, the outlook has completely changed. People are moving away from traditional preps, which are very invasive, to very minimal preps. So Emax and newer zirconias, they need only as thickness as 0.5 millimeters to give it sufficient strength, as long as they are bonded. Emax, remember that if you don't bond it, it does not get a sufficient strength for crowns. Concepts like verti prep, shoulderless prep, edgeless prep, these are all becoming actually quite mainstream. And because we're moving digital way, all of this is just marrying up really well, and that's the future. So there is a study by Ramos et al. 2014 of the shoulderless approach and the edgeless approach. I'm not going to go into it. Basically, shoulderless is when there's too much to explain. You can check these things, 2 things: shoulderless approach and edgeless approach. That's the BOPT technique, biologically oriented preparation technique. So there's a lot of problems that we think there is, like undercuts, excessive taper, 6 weeks waiting period. There's a lot of some issues there. But again, what they say is you need to have, you have to do it under a microscope or, magnification, and you need to have, their particular burrs to, create good. So So there are a lot of new approaches, it's all a lot of new theory. So to replace evidence-based, so that means for metal ceramic, all ceramic, we know it for about 20 years. Metal ceramic, we've got, evidence from 30, 40 years. So, it's something you want to go, you do want to do the new way, but you obviously don't want to leave what you have evidence-wise, because all this is new theories which just last 2-3 years. So we don't know how long they're going to last. So all of you, best of luck with everything, and you have to find your own path. Quickly wrapping it up, this is my logo. I'm actually doing a website. It should be probably published in the next couple of, I'm saying couple of weeks, but I don't think probably maybe 3-4 weeks, which I'm trying to do how dentists from India can migrate to the different countries. So the, the exams, the regulations, the visa process to all the main countries. So I am in the process of doing that. That's what I've been doing all of this COVID lockdown, and it's in the process of making, and that's when I got a call. So yeah, before I forget, I want to especially thank, firstly, my dear friend Deepa, who suggested to her classmate Mohsinka, who's the Ernad president, if I'm right, for inviting me for doing a presentation. It's my first webinar presentation, and I've got only 2 days to prepare. I wish I had more time, but I tried to squeeze a lot. Thank you, Shyam, who helped me a lot to techno-dumb me into sorting all this out. And thank you, Rose. And thank you, everybody, for listening. Sorry, I must have, there must have been a lot of things. I know it may not be exactly all married up, but it was a lot of information. And I think I picked a wrong topic for my first webinar because I don't even know my crowd. But hopefully it was okay. Thank you.
Yes, doctor. And we got 2 questions.